My name is Robin Hogan. I'm the Deputy Director of Public Affairs at the university, and it's my pleasure to welcome you to what will certainly be an educational and enlightening program this afternoon during a very sad and troubling time at Yale. I want you to know that we seriously considered postponing today's event in honor of Annie Lay and her family, her friends, and her fiancé. But Annie dedicated her life to science and to the pursuit of knowledge. And I didn't have the privilege of knowing Annie, but I would guess that she wouldn't want an opportunity like this to be canceled on her behalf. I would guess that she would say, go forward. This is a part of Yale's mission of education. And so we decided to do that. It was a difficult decision. And I'm sure there are a lot of your colleagues who are not here today because of their time of mourning and remembrance, and I honor that. I would like you to join me, please, in just a moment of silence before we start the program in memory of our lost colleague. Thank you very much. I want to acknowledge also that this panel is sort of the ever-shrinking panel. It started out larger. Jim Marone from Brown, a very well-known author and authority on healthcare policy, was going to join us until Monday afternoon when he called and he said his wife was very ill and he could not come over from Providence this afternoon. Also, Mike Waldholz, who was 25 years at the Wall Street Journal, now at Bloomberg News in New York, head of their bureau that covers education, healthcare policy, biotechnology, pharmacology, environment, and education, also called this morning at 9 o'clock and said because of the Baucus bill that was reported out today, and because his assistant is sick, he could not get out of New York. So that's the bad news. The good news is that Ted Marmor is so adept and nimble. He didn't lose a beat when I called him and said, we don't have a moderator. He said, I'll do it, and I'll moderate and commentate, and I'll make the distinction between the two in the course of the dialogue, and only Ted could do that. So thank you, Ted, for filling in those two roles. I'm going to introduce the panel and then get out of the way here and let the authorities talk about this important subject. Let me start with introducing our moderator and commentator, Theodore Marmor, one of Yale's foremost experts in welfare state policy and really the dean of health policy at Yale. He recently retired as professor of public policy and management at the Yale School of Management after a very distinguished career. He's written extensively, one might say exhaustively, on this subject in a variety of venues. He's the co-author or author of 11 books, published over 100 articles in a wide range of scholarly journals. He's a frequent op-ed contributor to the U.S. and Canadian newspapers. Canada happens to be one of the areas of focus of his work, the Canadian healthcare system. And together with his longtime law colleague, Jerry Mashaw, he regularly writes opinion pieces for the Philadelphia Inquirer. Ted lectures frequently on health policy, management, and law to both management and law students. He's an expert witness in cases ranging from constitutionality of the Canadian Health Act, asbestos disputes, and drug pricing fraud. Ted began his career as a special assistant to Wilbur Cohen, Secretary of HEW, back in the mid-'60s when I was an undergraduate at Yale. He was Associate Dean of Minnesota's School of Public Affairs, a faculty member at the University of Chicago, the head of Yale's Center for Health Services, a member of President Carter's Commission on the National Agenda for the 1980s, and a senior social policy advisor to Walter Mondale in the presidential campaign of 1984. He has testified before Congress about medical reform, social security, and welfare issues, as well as being a consultant to government and nonprofit agencies. Capping off Ted's long list of awards, the British Academy recently elected him a corresponding fellow, the highest honor the Academy bestows for scholarly distinction. Our second panelist has been, I think, probably quoted more than even Bob Schiller in the last few weeks about the subject we're going to discuss today. He tells me he's got a piece up on the New York Times site today on the Bacchus bill. Again, a journalist, an author, a scholar. He had perhaps the one mistake he made in his short career is that he went to undergraduate. He got his undergraduate degree at a trade school in Cambridge. But then he saw the light, and he came to New Haven, and he got his doctoral degree in the year 2000, joined the Yale faculty in 2002. He took a short hiatus to the UC Berkeley for a year, decided he didn't like living in the Bay Area, came back to New Haven as a full professor this summer, and we're delighted that he is back in New Haven. He enriches all of us. As I mentioned, he is a prolific writer. His most recent book is Health at Risk, America's Ailing Health System and How to Heal It, which he edited very recently. In his spare time, Jacob is a killer cyclist. So if you want to go for a ride up East Rock, before breakfast, call Jacob Hacker. Finally, our third panelist is someone who is well known on this campus, Dr. Stephanie Spangler, who is a physician, a clinical professor here at the School of Medicine, and a senior member of the Yale administration. Dr. Spangler has served as the Deputy Provost for Health Affairs at Yale for the past 14 years, and in that capacity, she serves as the provostial liaison for the schools of medicine, nursing, and public health. Before assuming that position, Dr. Spangler served as director of Yale Health Services, which is a healthcare delivery system that serves 35,000 faculty, students, dependents, and retirees. So she has run a substantial healthcare system and is an authority both as a clinician and as an administrator. She did her residency here at Yale New Haven Hospital and holds an appointment at the med school as a clinical professor in the departments of obstetrics, gynecology, and reproductive sciences. Just this month, you may have read a memo from Provost Peter Salovey that announced additional responsibilities for Dr. Spangler. She's now the Associate Vice President for West Campus Planning and Program Development, putting her right in the center of our efforts to craft the future of Yale medicine and science on our 136-acre West Haven campus. So I am looking forward, as all of you are, to what will be, I'm sure, an informed and measured and civil and articulate debate this afternoon. Really not a debate, but a discussion. This will be memorialized by two different television networks. Connecticut Television Network, which is sort of the C-SPAN of Connecticut, is taping this show in its entirety, as is our Yale Broadcast Center colleagues. So we will ask, if you would like to ask a question or make a comment, that you do so at the two mics in the aisles. You cannot speak from your seat. You have to stand at the mics, otherwise you'll just be a voice coming out of the ether, and you will not be on camera. So without further ado, please join me in welcoming our panelists.
Well, thank you, Robin, and thank you folks for coming on this miserable day and bearing with the weather to have what we hope is a civil discussion of healthcare reform, the fateful time that we're in. My fondest hope for this afternoon is that over the next hour and a half or hour and a quarter now, we have about half the time devoted to presentations by the panelists and some exchange between us, and leave at least half the time for questions and comments by the audience. My own view, in my capacity as a moderator and observer of the debate this in 2009, is that it's been, to use a technical term, a terrible debate. It's been marked by lies, distortions, twisted claims, incivility, screaming matches, and so on. And that's, I didn't expect anything like that here, but I also think, in addition to being uncivil, it was unilluminating, so that we've spent a huge amount of time hearing about healthcare reform and not learning much about what the choices are. So that's the aspiration for this afternoon. The second idea really is one of ground rules. I'm well aware of the difference between being a moderator and a speaker. And I don't have any illusion that even if I tried, that you won't have a sense that I might have strong views of my own. But I do have 30 years of experience of weekly moderating of a seminar, so I know something about it, and I think I'll be able to control myself in that role. And if I don't, Jacob, who's known me for many, many years, will actually play the role of a counterweight to that, I'm sure. And Stephanie, whom I've known for a long time as well, will also be there. The ground rules are these. I've got a series of questions that I posed that I hope we will get to either in the opening statements or not, but in the course of the afternoon. Let me just read them to you to sort of focus at least on what I hope we touch on. One question that I want to raise is, why did the strategy of reform of President Obama take the form it did? How come we're discussing healthcare reform in the light of the president's claims about problems and remedies? Secondly, what happened to that strategy over the last year and a half? How do we understand it? This is not speculation for speculation's sake. It's to make some sense of why in the United States we've had such a difficult time coming to even a resolution about what the problems are and what priorities they would have. Thirdly, where are we right now? What are our circumstances, both in reform and in American medical care? And even more importantly, what range of political results do we face now, in the near future, with what results for the country under the most likely outcomes of reform in the next month or two? Those are the general questions that I thought we ought to touch on as we try to have a civil discussion of American healthcare reform, the experience we've been through for the last year and a half. I have to say one more thing in the way of a story, and those who know me well will recognize this. But as I look on the audience, all I can think of is a true story that was once told to me about the difficulties of communicating to an audience. This has to do with the election of 1960 when John F. Kennedy was running for the presidency. He, after winning the primary, asked his staff to get hold of Governor Stevenson and get him to speak on his behalf, because Stevenson was such a great orator. They finally got Stevenson to do so. He went to Philadelphia and gave a speech. And at the end of the speech, a woman of mature years came up to him and said, rather worshipfully, said, "Governor Stevenson, that was the most wonderful, superfluous speech I've ever heard." And Stevenson thought irony was the right response, so he said to the lady, "Wonderful, given your response, perhaps I should publish this speech posthumously." To which the poor dear said, "Wonderful, the sooner the better." Being clear is not enough, but we'll start with trying to be clear about our views. Jacob Heifer first.
Well, thanks very much, and it's a pleasure to be here, even under these difficult circumstances. It's particularly a pleasure to be here because I believe so strongly that the medical profession and those affiliated with it really have to be on the front lines of finding a solution to the problems we're facing. Just 2 days ago, the New England Journal of Medicine released the results of a survey of American physicians that found that, contrary to sort of the common view of physicians as monolithically opposed to government in any form, circa 1950 fight against a Truman Health Plan, that in fact majority of physicians support something that I've been advocating for a while and have become identified with, a public health insurance plan competing with private insurance for the business of those who lack coverage today or who work for the smallest firms. And I was heartened to see that. In fact, about a fifth of physicians support a universal national health insurance system, sometimes called single payer, but Ted has always reminded me that that's probably the worst description you could possibly imagine for that kind of system. It's kind of like describing a house by talking about its plumbing. And so I'll just call it Medicare for all. Now, Ted and I go back a long way. I've heard the joke he just told about 35 times, but it never ceases. It never ceases to amuse me.
As a moderator, I'm going to limit you to those remarks.
But I'm the counterweight. So, and it actually is wonderful to have Ted here, both because he has brought so much to this debate over time, over a long period of time. Ted did not, I think none of you seemed to see the roast in that one, so I'll try a little better next time. And at the same time, he was the person who helped me get into this field in the first place. He was my mentor when I was back at Yale as a graduate student. Someone once said to me that you can divide your advisors into mentors and tormentors, and Ted was definitely on the mentor side most of the time. And he worked for Wilbur Cohen, which came up before. And so I want to start my very brief remarks, which I've already gotten well into, with a joke about Wilbur Cohen that's told, and that has a lesson for us today. Apparently, when Wilbur Cohen died, sadly, he went to heaven and was at the gates of heaven and was asked by God whether a simple question. God asked, Wilbur, will the United States ever have national health? Or no, sorry. Wilbur got to heaven. I really should have practiced this joke beforehand. Wilbur got to heaven, and he looked up to God and he said, I just have one question. Will the United States ever have national health insurance? To which he heard this booming voice, not in my lifetime. And I think in that joke lies a reality we all know. The United States has debated this issue since the early part of the 20th century, and yet we have failed, manifestly failed to resolve it. And with the exception of the passage of Medicare and Medicaid in 1965, we remain heavily reliant on employer-based health insurance, private health insurance that's eroding as the source of health security for working-age Americans and their families. And if anybody saw the Census Bureau statistics, they know that we are gradually moving toward a system where the government is playing a much larger role than most of us acknowledge, because as employer-provided health insurance has eroded, more and more lower-income Americans have been enrolled in Medicaid and the state children's health insurance program. But at the same time, we still have millions of Americans who are uninsured, some 46 million according to the latest statistics, and millions of more who are underinsured, who have coverage that's inadequate. And that problem is growing rapidly as well. Now, in the midst of this debate, you may be wondering, why is it? In the midst of these statistics, you may be wondering that why is it that this debate has so far seemed both so confrontational and, as Ted said, so divorced in some sense from a discussion of how we would actually address these problems. And I think it comes down to a central contradiction that was embodied in Obama's speech just a little over a week ago. In that speech, President Obama said there were 3 goals that he wanted to achieve. He wanted to make sure there were no disturbances in the employment-based coverage, private coverage on which millions of Americans already relied, but at the same time that coverage was extended to those who lacked it and made secure, and that the cost of coverage was brought down. That reflects the political difficulties in this country of challenging the employment-based system we've come to rely on. But I would submit to you that those 3 goals, are very difficult to achieve in practice. And just how difficult is revealed by the complicated nature of many of the bills on the table today, including, I think, the quite inadequate bill that was submitted today by Senator Baucus, the chairman's mark. And the problem really is that the fundamental changes that are going to be needed to bring down cost and to make coverage more secure are very hard to reconcile with the idea that there will be no change in the employment-based coverage on which Americans rely today, and indeed seem quite incompatible in certain respects. How do we make that coverage more secure without regulating it? But how do we regulate it without affecting it? How do we gain additional coverage when we know that millions of Americans are going to be losing coverage over the next decade without somehow intruding into the private system that we have come to rely on? And my argument has been that one of the crucial ways in which we can move in the right direction over time is to create a new public health insurance plan modeled after Medicare for people younger than 65. I've argued that this could be a backup for people who lack secure coverage today, a benchmark to press private insurers who are going to get scores of new customers, millions of new customers if people are required to have coverage, to improve their performance. And third would be a cost control backstop, because for all the flaws of public programs, the public sector has done a better job of keeping costs in check and could do a better job in the future. Needless to say, this idea, which remains quite popular not just with American physicians but with the public, has occasioned some controversy and may well not be part of any final legislative package unless there is a concerted push for it. And so what I would say today is that I think we start this debate now on Capitol Hill with every major relevant committee having introduced a bill, really not at the beginning, but still at a very preliminary stage in certain core respects. And what happens over the next few months in this fateful final months of the debate, I think will determine whether or not we have health security for most Americans or whether or not we repeat the failures of the past.
Thank you very much, Jacob. And Jacob is introducing both the problem side of it and the remedy side of it, which we'll turn to later on. And Stephanie, you wanted to speak partly about the delivery system side of this, so would you proceed?
Yeah. Well, first, it's really a thrill to be with Ted and Jacob. When I started my job at the health plan, directing the health plan, and encountered a number of challenges in managing the health of a population and healthcare delivery for a population, I decided I better get educated on what the policy framework and foundation was for healthcare, and attended Ted's health policy seminars, and they were just breathtakingly illuminating. And I would go back and try very hard to implement them in practice, and found a few difficulties as I came with, because Ted had really exciting sessions where people presented their works in progress. And I always wanted to offer Ted the opportunity to then come to the practice and see if he could come to the practice club after I went to the Policy Journal Club. But I come from clearly a different perspective and an experience than Ted and Jacob, but I have really been educated by each of them, and probably would have been one of those physicians in the Mount Sinai survey who favored the public plan that Jacob has put forward so eloquently. I think it's actually sort of, although it might be alarming in terms of the civility, I think the level of public discourse about this matter is actually quite thrilling. And I hope that sessions like these happen in many, many settings, many, many times, and that we all engage. I hope we can tone down the level of disagreeableness, as our president says, and talk about our disagreements. And I've thought a lot about why it's so charged, but also why it's so difficult to reach any sort of agreement. In the spirit of our civil discourse, let me begin with a point of seemingly common agreement that we all believe the healthcare system is in need of reform and repair. Indeed, it's been a subject of conversation since the turn of the previous century. That said, I also think many would agree that the term system is highly euphemized to describe how healthcare is delivered and financed in this country today. You may recall in President Obama's speech last week, he used the concept of ends and means in discussing the public option. Drawing upon that framework, which I find extremely helpful in many of my own endeavors, one could envision the U.S. healthcare system as an agglomeration of means to address a multitude of ends, some of them explicitly related to health and healthcare, and others that impact health and healthcare, but really were devised to achieve other purposes. The employer-based coverage is most notable in that it was devised in order to help employers attract employees at a time when wages were frozen. Embedded in this system are both explicit goals, not all of them directed at health and healthcare, and implicit motivations and incentives, some supportive and some at odds with the current system. What I think we can clearly say is that the current system does not consistently reflect the goal or comprehensively embed the accountability of providing access to affordable, high-quality health care to the United States population. We don't even have apples and apples. We have apples, oranges, and dump trucks with some bubble gum and baling wire thrown in. This system wasn't created overnight, making something this complex and amazing. It is the product of decades of disaggregated decision-making and actions serving a multitude of purposes, as I already mentioned. And already embedded in the so-called system that we have are the manifestations of the tensions that are riddling the current debate. We already have both private and government-run public systems. There are both federal and state responsibilities for payment in our current system. We have a panoply of provider compensation methods, from fee-for-service to capitation, and we already have irrational rationing. The system is fragmented, complex, unreliable, and often impossible to understand. Patients lose coverage when they change or lose jobs. Coverage changes without consultation. Providers cannot follow panels of patients over time when coverage and employment and insurer decisions throw those patients right out of the network. My colleagues in academic medical centers absorb millions of dollars in costs for patients with no coverage and no ability to pay. Insurers face endless requests for coverage for the latest, newest, most expensive, and maybe the best technologies. All that said, we Americans are nothing if not unfailingly, and I think sometimes masochistically, resilient and adaptable. And most of us have struggled mightily to make sure that we have coverage, or the job that provides the coverage, so that we can see the doctor our friends recommend and get the treatments advertised on last night's TV. There are thousands of little, fragile, adaptive ecosystems of patients and providers, and even payers out there, holding on, in some cases literally for dear life. It's no wonder they don't want to change the system that they're in. But just because it's hair-raisingly complex and difficult is no reason to step back and wait. In fact, it is a very good reason to forge ahead. We cannot wait until another day or another year, which will only add to the pile of non-focused, implicit decisions and actions that will further complicate the system and likely have untoward effects on the health of at least some segment of our population. It is likely that we will have to practice some sort of strategic incrementalism, but we will probably not get anywhere except deeper in the muck if we don't explicitly and embrace and hold high our common goal and identify the necessary, if not immediately sufficient steps to get there, which is accountability for the health and health care of the whole population. Now, with regard to the current debate in my perspective, I'll get a little bit more specific and speak from my areas of interest and knowledge, which are healthcare delivery and the training and development, care and feeding, if you will, of the workforce, healthcare workforce. Much of the discussion and a large amount of text in the proposals deal with the healthcare financing system. Who's paying the bills? What are they paying for? And who by default is absorbing the uncovered costs? In any event, the delivery system, not surprisingly, reflects the same fragmentation as the financing system. They grew up side by side. Most physicians still practice alone, in partnerships, or in small single specialty groups where they have limited capacity to deliver comprehensive care, implement electronic medical records, or work with multi-professional teams of providers. They're severely challenged by the revolving door of patient eligibility, frequent fee cuts, and ever-mounting administrative burdens dealing with multiple insurers. Most are compensated on a fee-for-service basis, which rewards volume and intensity, and rarely quality and efficiency. And they lack good data regarding what good care is, what works and what doesn't. Over recent years, we've seen innumerable studies from many of our colleagues in academic medicine, highlighting the differences in care that patients receive in different parts of the country. This was most memorably portrayed in the New Yorker in the McAllen versus El Paso, Texas story. According to Harvey Feinberg, the president of the Iowa Institute of Medicine, in a very lengthy review of comparative effectiveness research, for want of appropriate studies, innumerable practice decisions facing patients and doctors every day do not rest on a solid foundation of knowledge about what constitutes the best choice of care. One consequence of this uncertainty is that highly similar patients experience widely varying treatment in different settings, and these patients cannot all be receiving the best care. So fee-for-service is based on volume, not value and efficiency, but fee-for-service without any database to guide quality and effectiveness is guaranteed to be cost inefficient. To make it short and simple, the configuration and fragmentation of both the delivery and the financing systems leave us with no one at home when it comes to overall accountability for quality, effectiveness, and efficiency of care. While there is insufficient data regarding which treatments and procedures work, there is even less data on how different delivery systems work. Certainly the cost effectiveness initiatives are impressive and call for a whole range of measurements regarding which treatments work, which procedures work, but there's very little research being done on which healthcare systems work. I'm pleased to see that largely through the public media, there are a lot of anecdotal stories about Geisinger, Mayo, San Francisco Health, Massachusetts, the Fairview, Minnesota clinic, which is called the Sandbox for Healthcare Innovation. We actually have our own innovative delivery system at Yale through the Yale Health Services, and I, as a provider, was really enlightened to see what I could do when I operated in a different healthcare delivery system. a system that was responsible for both financing and delivery. It took full accountability for the population of Yale. There were no pre-existing conditions or exclusions. Physicians were largely salaried. There are teams of healthcare professionals who provide care across a continuum. A unified medical record, which is now electronic and generate data. Disease registries that allow for proactive attention to chronic diseases and preventive care. Alternative modes of care that don't generate a fee in fee-for-service practice, such as telephonic care. And it allowed basically for experimentation, innovation, and measurement. And it's cost-effective. All of these models have common themes: integration of care, alignment of incentives, and support for innovation. Now, I'll finish very briefly by talking about a little bit about workforce issues, where again, we have fragmentation among provider groups, different credentialing and licensing criteria. It takes a long, long time to train and change the workforce. And without any change in the delivery system, analysts now are projecting nationwide shortages of almost 100,000 physicians, as many as 1 million nurses, and 250,000 public health professionals by 2020, and that's without healthcare reform. If we now expect to move 47 million people from their primary care in emergency rooms to primary care in physicians' offices, if we want to place accountability for the assessment and delivery of care in medical homes, teams of diverse professionals, ambulatory intensive care for complex chronic disease, and accountable care organizations, any reform measure must have robust provisions for supporting the analysis and innovation with regard to delivery systems and structures, including provider compensation, and it must have explicit mechanisms to assess and address workforce development needs, the training of physicians, nurses, public health professionals, ancillary health professionals. The only way the current reform proposals can fortify the workforce analysis and development, I think, I shouldn't say the only way. One thing I note in all of the proposals for healthcare reform, and this will be my final comment, is that the only place that we currently have in our so-called U.S. healthcare system where we can actually collectively innovate and analyze is through the publicly provided healthcare systems. It's through Medicare and Medicaid. If you look at all of the healthcare reform proposals, there are indeed provisions and support for some innovation in healthcare delivery systems, and certainly a lot of support for cost-effectiveness research in terms of individual procedures and treatments. But those only can occur in the publicly supported systems. So either we must find a way in reform to stimulate that kind of innovation and support for innovation in the private sector, or else we'll only be innovating in the populations over 65 and under 133% of the poverty level. And I would argue that we're not going to get an adequate and full picture of what the needs are of our population. So I will stop there.
Well, what you've had so far is a commentary about a debate that really hasn't finished. It had hardly gotten off the ground. From Jacob and from Stephanie, you've had a list of the ways in which the American healthcare arrangements fall short on many, many dimensions. And I disagree with both of them. I don't disagree because I don't value their values or their standards, but I'm now going to shift to a speaker, and I'll get back to be a moderator in just a moment. What I take from Jacob's description is that we spent the last, year and a half talking about problems, solutions, and politics, and we've hardly had any agreement whatsoever from anybody. The fact that we have 5 different bills tells us that we have not been able, with the President's assistance or the Congress, to put a priority, to have a conception of what the problems are that are widely enough agreed upon by enough people to act on. And we've got a cacophony of noise when we talk about something called a public plan. The public plan doesn't tell you what the public plan includes. The President has not been able to describe what makes a public plan public. Jacob has, and Jacob did a very interesting article about the good, bad, and the ugly in these particular forms. But here we are in September of 2009, for months having talked about a public plan, and there's no agreement on what it would include, whom it would include, and what role it would play. That's problem number one. Problem number two is we've had, for the last year and a half, a rhetorical position taken by the President that choice of insurance plan and competition among insurance plans will constitute both a mechanism of holding quality to a higher standard and a mechanism of cost control. Those are aspirations, not based on the reality of anybody's experience. The two systems that I know of that have tried to have universal health insurance with competition among private insurance plans are Switzerland and the Holland. And in both those cases, while they do have universal coverage, that's true, they have not been successes at cost containment. And if it's true, as the president has said, that we can't live with the costs we're facing and they're projected going forward, I think it's crucial that we speak candidly and forcefully to the central fact about cost control that's so often lost when we talk about ways of improving American medical care, and that's this: that if the costs are going to be less than they would have been otherwise, the incomes of somebody in the medical care system have to be less than what they would have been otherwise. A dollar of expenditure must be a dollar of someone's income. That's an indisputable fact. And unless you face that and are willing to talk about that, rather than the virtues of prevention, which are great but don't solve the problem of cost, or the virtues of electronic medical records, which may well work out but won't save costs necessarily, or the wonders of giving up cigarettes, God knows what, or become leaner. All of those things are worth doing, but they don't have anything structural to do with the central feature of American medical care in the last 40 years, which is that we've had insurance for some, we've had no countervailing power over the whole system in order to restrain the understandable wishes of people in the medical care world for more income. And every other country that I know in the OECD world balances the wish for more and better care with restraints on the budget for medical care. Now, that's my view, and that it doesn't say either that Stephanie's wish list of an accountable medical care system is in any way not to be sought. But it doesn't say about Jacob's hope that if we had a good public plan over time, it would have these effects. Rather, it says the political dilemma we're in is that the menu that was announced today by Senator Baucus doesn't do much at all about any of these problems. And here we are in September, not absolutely clear that that's the case, and with Baucus not embarrassed. The shamelessness of these characters, the degree to which they talk what you might call fiscal babble about this, the extent to which we haven't learned a damn thing from other people's experience. We've had the most provincial debate I can possibly imagine over the last year and a half. To the extent we've talked about any other country, it's been Holland or Switzerland, which is not well known in detail in the United States. Not a word about Canada, except ads by Richard Scott of Columbia HCA announcing one lie after another about Canada. Other than that, things are wonderful. I just want to assure you. They're just wonderful. I just wanted to make sure that we don't have complacency of any sort. And there is a form of complacency, in my view, that comes from holding on to aspirations for an overall reform that will address all of the problems of cost, quality, and access, when that's not likely the roads we're going to take in the United States. Our political system is designed to make it difficult to do that. And that's why, as Stephanie said, energetic incrementalism is about what we can hope for. But then, if that's true, and this will be my last point, and we'll turn it back to my colleagues, if it's true that in the absence of a tornado of change in the political composition of the Congress, we will, at best, have increments of movement on the financing of insurance with some attention of it. If that's true, then the central question of the healthcare debate of 2009 is what incremental steps will put us on a glide path to getting to the problems that we've been talking about down the road. And that's the debate, it seems to me, we've not had. I would like to debate, Jacob, not tonight, not today, because I can't in my role. about the comparative advantages of moving in the direction of lowering the age of Medicare downward and having a catastrophic plan through the tax system for the rest of the population and having a pincer movement from the young to the old. But I'm not going to do that. All I want to do is make sure that as we raise questions here, and particularly from the audience, that we take into account that we have had millions of words written and spoken in the last couple of years about healthcare reform, and the bulk of the population is utterly confused about what the priorities are, what the characteristics are of the alternatives, and have been fed a packet of distorted commentary by our media. Let me just add that last point. It's really important to take into account that much of our media, not all of it, operates on the assumption that if you quote both sides of an argument, you've contributed to illumination. And if one side of an argument is a lie, that doesn't actually contribute to illumination. It amplifies misrepresentation, and I think that's part of the reason here we are in September, the middle of September, and we have a situation in which today a bill was proposed that has, I think, almost no chance of getting through, having had months of negotiation among 6 senators who represent 2.4 million Americans. As I said, everything's terrific. So let me shift from that gear into my moderator's role and turn it back to the panel with any comment they want to make, either about their own or my or Jacob's or Stephanie's point, and then I think I'll open it up to the group.
Well, Ted said that he disagreed with me. However, I would say that we're probably on the same page in terms of our assessment where the debate is. So let me disagree with myself, only because I don't want to leave the impression that I think that all is lost by any means. And I want to emphasize a few facts that I think should be kept in mind about how much progress we've actually made in this discussion so far, notwithstanding the shrill charges and countercharges and the very difficult questions that remain. Ted can correct me if I'm wrong, but I believe at no point in the past has a bill for near universal health insurance actually been reported out of a congressional committee. Maybe the Wagner-Murray-Dingell bills were reported out, but no one ever thought they would have the chance of being voted on. We now have 4 congressional committees, the 3 in the House and the Senate Health, Education, Labor, and Pension Committee that have put forward bills. And as this brief that Ted mentioned, the good, the not so good, and the ugly, the rundown of the good, the not so good, and the ugly in these bills, that there actually is there is a lot to value, particularly in the House versions of the legislation. Now, reverting to my slightly more pessimistic self, let me just make 3 very quick points in response to the comments so far. It seems to me that the fundamental issue we were asked sort of where are we, what is the strategy President Obama chose, and where are we now? I think it's pretty clear. I've already mentioned that one of the difficult aspects of this strategy is squaring the circle of trying to build on the existing system while fixing what doesn't work in it without disturbing the employment-based arrangements on which millions of Americans rely. It's very difficult to do, and it creates such perverse provisions as, for example, in Senator Baucus's plan, if you are offered employer-provided health insurance, you have to take it unless it represents more than, I think, 13% of your income, just the employer portion of the premium. And that employer insurance is exempt from all the other regulations that would be subject to the small group and individual market, except for a requirement that it covers preventive services and that it not have total out-of-pocket costs greater than health savings accounts. Needless to say, this is not a very reassuring provision for those who are worried about the quality of or the cost of the coverage that they have today. The central political fact with which President Obama has to grapple, and which I think he recognizes and his advisors recognize, but have had a very difficult time grappling with, is that there is literally no Republican support outside of Maine for the kinds of measures that he wants to be passed. Senator Baucus engaged in a Sisyphean task of trying to attract 3 Republicans to support reform, Senator Enzi, Senator Grassley, and Senator Snowe. Even Senator Snowe, the most moderate, more moderate than many of the most conservative Democrats in the Senate, has not yet signed on. We are living in a hyper-polarized political environment. That's why the talk is about end runs around the filibuster within the Senate and the question of whether or not some conservative Democrats can be attracted to end a Senate filibuster, which requires 60 votes, even if they may not vote on final passage of the bill. I think we should, in addition to the institutional hurdles, just keep in mind just how difficult it is to create compromise in an environment in which there is such a gas gulf between the two parties, and one party, the Republican Party, it does not support some of the core elements that President Obama and many of Americans, the majority of Americans, support to achieve reform. Two quick observations. I agree with Ted about—
Emphasis on quick.
Quick, okay. Two quick observations. I agree with Ted about private health insurance competition having a limited ability to bring the kinds of long-term changes that I would like. However, I do think that it's important to understand just how little competition there is in the insurance market today, because I think it's an important reason for having a public plan competing with private insurers. The number 26 I use a lot. That's the number of states in which the largest private insurer has more than half of the privately insured population. So in 26 states, more than half of people are enrolled in the largest private insurer. WellPoint, United Health together have vastly more enrollment than Medicare does. And it's a real puzzle why these plans with 30 to 40 million members haven't been able to do a better job controlling costs, but they haven't. Right. And so I think it's really important to understand that in those areas, a public plan would be a very powerful inducement to these plans, I believe, to lower their costs. Last thing, I think the most grave problem we face is not the dispute over the public plan. It's not the dispute over the subsidies. It's financing. It is always financing. Where will we get the money? So there are two equations. That every dollar that we try to save is a dollar of somebody's income. The other equation is that we have to raise money, substantial sums of money to expand coverage, even if we know this could save the federal government money over the long term. And how much that is, it seems to me, is this sort of fixation on is it 900 billion or 1 trillion or 1.1 trillion over 10 years is very misguided. But there is something we should be fixated on. Can they raise the amount that's required, right? And that's why right now the leaning is so heavily on trying to cut spending within Medicare, which has created a lot of concern. And at the same time, there is this just round robin of ridiculous proposals to raise money, from taxing the highest end health insurance benefits to putting windfall profit taxes on providers because they'll suddenly get money for uninsured patients, previously uninsured patients. Just go down the list, right? If the Senate members of a majority or supermajority in the Senate are not willing to support some kind of progressive tax that's going to raise funds, it's going to be very hard to see how this can get done. And that's what I lie awake about right now. Surprisingly, it's not that the public plan will be substituted for, co-ops will be replaced the public plan, or that they'll come up with some crazy trigger. I lie awake just thinking that there will be this sort of firing squad over financing where everybody shoots each other's proposals and there's not enough money to do this.
Thank you, Jacob. Stephanie?
I'll say just a few words, and I didn't.
Let me just alert the audience. We've got these
We're moving to
microphones on the side. Start thinking about what you'd like to discuss as Stephanie has her say.
In fact, migrate to the microphones, and I'll be even shorter, briefer. So I didn't hear quite the disagreement that in your comments, Ted, with what I said.
Well, then I wasn't clear enough.
But I'm sort of violently in agreement with a few things that you said, and also with what Jacob said. Actually, in my experience, we are closer to agreement on universal coverage than I think we've ever been, and I'm speaking not just from governmental and legislative and political perspectives, but from the provider community. It has been disappointing, I think, to many of us that in previous debates, the provider community was one of the biggest obstacles in trying to preserve the system that had that has been with us for some time, and the provider community has come forward with a lot of support for coverage. That said, there's also still a lot of concern about blunt instruments in terms of financing, and I think that without the kind of information that we need about the delivery system, there are few instruments other than blunt when it comes to exacting savings from the delivery system. And I think it would be, I think we have to go cautiously in terms of promising big savings in Medicare and Medicaid without aggregating the data that would cause us to do that rationally, thoughtfully. And yes, some people will lose dollars.
No, it must be the
that we
case.
save.
It's not a
If we're
matter of
gonna save,
opinion.
if we're
It
gonna
has
save.
to be the case.
Right.
Somebody must lose if costs are going to be controlled from what they otherwise would have gotten, period. That's not
If
not
costs are
up
gonna
for
go
grabs.
down. I agree
Or
with you.
go down from what they would have been.
Right. I'm not disagreeing. I'm just saying one instrument that the provider community is very concerned about is the the university is concerned about this right now too in terms of our economic climate, is across the board cuts without thoughtfulness. And so I too worry that we're going to need to front load the system with quite a bit of investment that comes from somewhere other than across the board subcortical irrational cuts in the delivery system, but with the expectation embedded in it that the delivery system will gather and use effectively data over time to analyze where those dollars are that should be taken away. And actually, just as a quick anecdote, even at the health plan, we've seen as we've brought on providers who've worked under retainers or capitation, we've seen them examine their practices when they felt they couldn't live under the capitation and actually modify those practices. Again, dollars came out of someone's pocket because they reduced the number of procedures. But it can happen, and I think what's really refreshing is to see the literature changing to think more about some of this data collection and analysis. And finally, in terms of strategic incrementalism, again, one thing I find refreshing is not everybody is just knee-jerk reactive, although it's depressing how many people are in this debate because it's usually save mine, whatever mine is, save it. Mm-hmm. And instead of embracing a common vision, there are some people who do. I think Obama's been pretty compelling, at least for some of us, in at least creating that vision that you're heading toward. The details, of course, are difficult. And someone at a conference here recently described strategic incrementalism. At least you have to know you're going to Boston. Because then if you're standing on a highway and a car comes by going south, you won't take that car. If you don't know where you're going and you're hitchhiking, you'll probably take any car and end up someplace that you didn't want to go. So I think in terms of strategic incrementalism, we at least need coverage, we need a way to stimulate innovation, we need a lot of data in order to really understand the costs of the system.
Well, thank you very much, Stephanie. Thank you, Jacob. We've got a little more than half an hour, and I want to turn to what I said would be ample time. And I was going to say I'm going to turn first to the left, but I'm not going to. I'm going to turn to the right first, and we'll go back and forth. Sir.
Thank you. As a provider in New Haven, I'm actually a primary care physician in downtown New Haven, and I was struck on the basis of your comments that one particular phrase which I feel is very important is primary care. And I heard that phrase once from Dr. Spangler. And as a primary care physician, recognizing that the workforce issues are very important, that access is very important, I think I would agree completely that some people are going to lose, including providers. And I think that there needs to be a much more frank debate on certain subspecialties, potentially who are getting paid a lot more than primary care providers. I'm active in the American College of Physicians, and they've been pushing along with the pediatricians and the family physicians various ways to try to back up the primary care backbone of our system. And I was wondering kind of how important is that? It's in a lot of the bills, but it seems like that at times is a small part of the debate, but really not nearly enough.
Fine. I think my short answer would be the one thing that I do see arriving at a point of almost consensus is that we should be paying primary care physicians more and specialties less. So of all the things not accomplished during the last year and a half, the issue you raised is the one that has got a substantial level of at least verbal consensus. Whether when the fight comes it'll be acted upon as another one, but I don't think you should treat, I think you should say that of the problems of American medical care, the remuneration of primary care activities as opposed to super specialty activities has been acknowledged. Now maybe you two would disagree. I don't think so.
I agree that it's been acknowledged, but I think it's so vitally important, and there has been less attention than there should be to how this could actually be done within existing programs. I mean, it's notable that the debate that's taken place over the public plan and over Medicare, that a lot of it has concerned issues quite distinct from this question of how you would change the relative payment rates for primary care physicians and specialists. And everyone agrees that that's out of whack. And I have to say is one of the best arguments, if you will, against a public plan to me is that the disproportionate political influence of the specialties and the device manufacturers in their ability to keep this a payment formula that a lot of people acknowledge really undervalues primary care is something that really has to be dealt with. But I do think that the best way to deal with it is to make sure that the public sector is really leading the way in showing that this is where dollars should be. And that's why I think it's really vital that the public plan be available not just to people over 65 as it is today, but that there be some kind of public insurance plan that's there for people younger than 65 who aren't poor as well. So that's all I'll say on that, but I think that's crucial.
I certainly think that the public's hopes are sort of centered on some sort of accountability in the delivery system, and that accountability seems to be on concepts like medical home and
Right.
certainly primary care, and there are components, even in the Baucus bill, of support to expand the number of primary care physicians. My concern is the way the system has evolved, and with the implicit and explicit incentives, is that we have far more specialty care than we do primary care. So, and I was interested in reading, there was a report from the Physicians Foundation, which represents a lot of the state medical societies, and those physicians actually suggested that we might have to, in the short term, shift responsibility for some of the primary care to non-physician providers and have the primary care physicians sort of be the grand managers of multiple non-physician providers. I think the real issue is lead time. Even if we decide tomorrow we're going to stimulate primary
whole
care,
generation.
we are
That's
not
right.
going to have primary care expand, as you know, tomorrow. So.
Thank you.
This is a convention that we probably should honor, which is to announce who you are as you speak.
I'm Dr. David Fisher. I'm a medical oncologist. I've been on the faculty of Yale Medical School for 45 years. I've had my role as full-time member of the faculty, part-time member of the faculty where I practiced in town, and I'm back at full-time now. And what I've noticed is that there's a lot of fat in the system. We talk about some people having to lose coverage or something of that sort, but there's a lot of fat in the system.
What do you mean by fat?
I'll tell you. Our oncology drugs now
you.
cost between $2,000 and $5,000 to $10,000 a dose given every 3 weeks. And for many of them, there are equally good drugs that are generic that we've had for a long time that would work just as well. But the pharmaceutical companies justify the high cost of the drugs by saying that they spend so much on research. In fact, they spend more on marketing, on television and to others.
Those facts are within the health policy community are well known.
Right.
What would you suggest that
Well,
we
I
do
think-
about that?
I think we need a system where there is no advertising directly to the public.
But again, I'm trying to push you a little bit on the political realities. You've known, and many people know for a long time.
Well, the political reality is that the pharmaceutical companies are so rich that they fund a very large part of every congressman's war chest for re-election. And I don't know what to do about that. The same is probably true of the insurance companies, which spend an enormous amount not insuring us, but on advertising that they're better than the other insurance company.
The reason
And
I'm
finally,
pressing you is that this recitation of these horrible circumstances is quite common. And the problem we have in September of 2009 is what, if anything, can you imagine being done about the facts that you just cite?
well, they're very difficult. But one of the problems is we ourselves are part of the problem. We have now abandoned the history and physical examination most of the time to get an MRI, a CT scan, a plethora of blood tests, all of which raise the cost of medical care far beyond what is necessary. Part of it we do because we're afraid that we might be sued if we don't get a CT scan and an MRI on everybody who has a headache, because there's a 1 in a million chance or 1 in 100,000 chance they might have a brain tumor. And we have ceased playing the role of a careful physician because we're afraid of litigation. And we spend a lot of money on litigation, and I don't understand why the Obama administration hasn't really taken a hard look at that. They say the costs of insurance for that are not important, but the fact that we practice medicine driven by that, I think, is a very major problem.
Someone want to comment about that?
Go ahead, Ted.
No, I'm gonna be moderator for now.
You are, okay.
I'm gonna save my
How
moments.
could we tell? So,
As I understand the question is, why hasn't the Obama administration taken more seriously
Tort
the
reform.
defense of medicine and tort reform? Is that right? Right. All right.
well, I think it certainly got mentioned. And I'm going to leave the political climate to you. But certainly he finally mentioned it last week. And certainly I agree with you that there's a lot of defensive medicine being practiced. And there's also a lot of subtle as well as explicit advertising and pressuring from drug companies that's going on. By the way, I think all of the reform bills, except I didn't see it in the Baucus bill, do have some version of the Physician Sunshine Payment Act that would require pharmaceutical companies to post all payments to physicians to try to diminish the practice of luring us all with the pens, pencils, and doctor bags that we all got in training, and that's probably quite a good appendage to the bill. I think so there is the fear of malpractice. I also think that, I'll come back to the dead cat I keep putting on the table. I don't think we have a delivery system that allows us to aggregate data once a treatment or procedure has been approved. There's a lot that goes into the approval of a drug or a treatment, but once they're out there and being used in practice in our fragmented delivery system and without the kind of supports to allow us to collect data in an organized way, you have to be even more defensive because you don't have the kind of data that supports the less expensive decision. So I would say it's a combination of tort reform to remove that perverse incentive, but also information to encourage the best decision.
Jacob, you want to?
No, I think we should get some more questions.
Okay. We'll have a private conversation about how it's so hard. Okay? On the right here.
Thank you, David.
My name is James Lynn. I am a political activist and also a user of healthcare services. I am in Medicare, which is a single provider, and also I'm in the VA system, which is socialized medicine, basically.
And the question is?
And the question is...
Or the comment.
Or the comment is, to begin with, I'd like to throw this little frisbee out. There is money to finance health care. Currently, the U.S. military budget is using up almost half of the discretionary disposable income in the budget. And this is certainly not something that you all could speak to because this is a much larger political issue, but I would like to put it out that there is money given the political will. The question, I'd like to pose a question to you though.
Okay.
I said I was a political activist. I'm working as hard as I can, and with a lot of other people, to ensure that there is a public option in the health care plan. And
You've just relieved Jacob's hypertension.
Exactly. Slightly.
You haven't cured it.
Now
That's
you have to take care of Max
cost-effective treatment,
Marcus, right?
Ted.
I said relieved it. I didn't say cured it.
And
Pose the question you want to pose for us.
and also I'm from Montana, and Max Baucus has been, I've known about him for decades. And
Fine.
I guess Ted Kennedy was asking God when Max would leave the Senate, and God said, "Not in my lifetime." But the question I'd like to pose for you is to talk about the idea of a continuing logjam in the Senate, in Congress. People insisting on the public option, people offering much more watered-down versions.
Right.
So I would like you to discuss the possibility of that.
Yeah.
Okay.
Well,
Jacob.
I think, we've reached a bit of a logjam now, so let me just sort of move over, put on my political science hat, and tell you a bit about what I think is going on and where it might go. And the first thing to say is, I've been involved in this discussion of the public option, which I like to call public plan choice, for quite a while. And every time that it's looked as if the idea of the public plan had been decisively buried, it's been resurrected. And I think there's a pretty simple reason for that. The very stories that we've just heard about some of the problems in the private insurance industry and the fact that it's very difficult there aren't many other ideas on the table for long-term cost control that are being embraced at all, has made the public option an attractive idea. There is very strong public support for it compared with a lot of other elements of reform. Put the individual requirement to have insurance up against the idea that there should be a choice between public and private insurance, and the latter will win every time. And so I think that we've seen article after article saying, that this is it. They finally got rid of it. They've driven the stake through this option. And each time it comes back. So I look at this discussion right now with those eyes. The central problem is, and has always been, the Senate. And the Senate is a distinctive institution, shall we say, right? It has 2 senators from every state, right? So it's grossly malapportioned. And it also runs on a largely supermajority system. That's not always been the case. The filibuster has become a much bigger constraint on policy change in the last few decades, but that's how it is now. So you need 60 votes to pass anything of significance in a body where 10% of the population, senators representing 10% of the population can sustain a filibuster. Senators representing 10% of the population, if you take the smallest, least populated states and add them up, represents 40 votes. So really should understand that if this were just the House of Representatives, we'd be very close to passing a bill that had a public insurance option. Now the question is what's going to happen on the Senate side. And I hate to go into sort of these political science details, but I think that if you care about this debate, I think there's 3 things to understand. First of all, this is a case in which, if there's a sense in which there's broad support for this among Americans and active support among Americans, it's going to make a difference. Because there are a lot of senators who are literally on the fence about, or not literally, but on the fence about this issue. Second of all, the real question is, with regard to the filibuster, is whether or not some of the more conservative Democrats or a moderate Republican like Snowe that would be conceivably likely to vote for a final package or to vote to end a filibuster, whether they would actually sustain a filibuster over this one issue, right? It's not whether or not they would eventually vote for it. It's whether or not they would allow a final vote. So if the public plan can gain support of a majority of senators and enough support among another 9 senators or so that they would not be willing to sustain a filibuster over it, then it can pass the Senate even without 60 votes of support directly for it. Lastly, this whole debate right now is running towards a serious logjam, and not specifically over the public plan. It's over the fact that there is there's going to be progressive revolt over what Senator Baucus has put forward. Many would like to do something closer to the Health, Education, Labor, and Pension Committee bill on the progressive side of the party in the Senate. President Obama desperately wants a deal. So there's going to be a lot of pushing to try to get the Democrats to sign on to something, anything that can pass. There's clearly flexibility about the idea of the public plan. But it's really quite possible that there really isn't majority support or supermajority support for any piece of legislation, with or without a public plan. At which time, or rather, there's certainly not supermajority, sorry, at which time then the last parliamentary maneuver that should be mentioned is the budget reconciliation process.
Which he will not go into, but it takes 51 votes.
It takes 51 votes to pass something if it goes through the budget. And then the question becomes, what can you do through the budget process? These are the parliamentary procedural choices before the Senate, and they actually turn out to be pretty crucial to whether the public plan will succeed or fail. But I come back to my first point and say that I really think this is a case where demonstrated public support and activism about it, and the continued argument that Senator Rockefeller and others have made that there is really no viable substitute to it are going to make a difference going forward.
Now we've got 6 people. Let me ask you to please pose a question or make a comment that's brief so we can respond to it and make sure that people are not standing in vain. Yes, sir.
My name's Chris Gottschalk. I'm a neurologist who, after 10 years back out in private practice, has rejoined the Yale faculty. I would like first just to thank you all for what is already an enormously illuminating conversation, and in particular relieving me of my guilt of having spent so little time reading what some of these debates are, because now I see most of them are superfluous, and I have a better idea of where to focus my attention.
Splendid.
So the question I have, or the issue I want to take up, is a little bit about this idea of, say, specialists versus primary care. Really, the question being, is it really physician fees or office fees that are the big problem in this debate?
The short answer to that is no.
All right, so help me please understand, in the large field here of physicians' fees versus medications versus surgical and hospital fees, and how do you factor in the numbers that we see thrown around about how many billions of dollars are lost due to an illness?
It's easy to simply get overwhelmed by these numbers. $2.4 trillion. It's almost impossible to conceive of it. If I put it in percentage terms, I say physicians perhaps are 18% of the total bill. That's a large number in terms of billions, but as a proportion, quite small. Hospitals, something between 35 and 40%. The pharmaceutical industry gets a lot of attention, but it's something between 12, 13%. It used to be 8. On the other hand, it's controlled by a very small number of players. So the concentration of capital has a disproportionate political impact and viability, and they have more, as you probably know, more lobbyists than Carter had liver pills, if Carter had any liver pills. But I think you don't want to go down that road. It's not important whether it's 18% or 19%. The question at issue that causes attention is, if you want to draw more physician students into primary care activities, and you want to do so by rebalancing the rewards of intervention on the specialty side, it engages this loss to one of an aspiration and a gain to another. That is precisely the kind of politics of struggle that we're used to in labor management. There's never going to be easy. You should never expect it to be so. And then there's an additional element here that's here. It's this hope that were we to be able to get more primary care physicians or helpers to primary care, and we created something ideally called a home, although no one's ever seen a home called a primary home, that would be somehow magic. Well, it wouldn't be magic. We don't have no idea about actually how these homes would work. It's a perfect illustration of aspiration defeating actually planning. It's one of these fads that has gone on. It's aspirationally, impressive, but it's got actually no structure to it. So I think you're getting here a concern about how, it's really a concern that's reflected in the Massachusetts experience, where they expanded insurance and then found a lot of blockages at the level of delivery. And I would say, the way to put it in a nutshell, is that most of the reform discussion has indeed been about the financing of care that you can get. It's not about getting care that you don't have. And it's important to realize that the financing is in and of itself a separable problem. I hope that helps.
It does.
Well, that's enough then. Thank you very much.
I would like to add one point to that, which is, although you may say physician fees are a small proportion, physician decisions make up a
Huge.
much larger portion
Huge,
of the healthcare spend. And so I think as physicians, and what we can do is think about how we can better support our decisions in terms of use of resources.
So can I throw one
No,
twist?
you can't.
Thanks for
tough.
your time. My name is Jorge Galvez. I'm currently a resident in anesthesiology and will be pursuing a career in pediatric anesthesiology, formerly Yale medical graduate. So I have two-part question. One is, I understand that at some point there's going to be some form of reappropriation of physician reimbursements. One of the things that doesn't make sense is also there's a big disproportion in the costs of malpractice insurance across specialties. And if you're going to cut income in physicians, I think also there needs to be serious consideration about
So what's
these issues.
the question?
So one is,
Suggestion.
just along those lines, if there's any real hope for this. And the second part of the question is, given that we're probably not going to make sweeping changes overnight, is there any role in making changes to areas that might be helpful? For instance, preventative care in the obstetric population, women and children, preventing, early labors, admissions to newborn intensive care units, lots of surgeries, and costs in that regard.
Targeted intervention.
Correct. So instead of coverage for everybody all at once, for instance, coverage for all women of reproductive age and all children, for starters, and then adding to other parts of the population. Just for a thought.
Okay.
Well, I mean, I think what's interesting is that that's really the route that we've taken with the low-income population, starting in the 1980s with Henry Waxman's pursuing expansions to pregnant women, low-income pregnant women and children, and then the creation of the Children's Health Insurance Program in 1997. We're at the point now where we have a kind of de facto kind of halfway coverage for millions and millions, more than in Medicare, of Americans who have low incomes. And the system, I think, is enormously better than what prevailed before. But the problem, of course, is that we have millions more people who are losing coverage over time in the employment-based system. So the one real concern I have with going down a route where we're simply expanding to coverage populations, as we did with Medicare in 1965, and to the disabled subsequently with Medicare, is that we don't make that next step. It's not self-reinforcing, and it's not fast enough to deal with the erosion of coverage. Moreover, there's this problem in our system, and I think this gets back to a lot of the comments we've had, that because it's so fragmented, there just isn't, as Ted said, countervailing power on prices and on incomes and on administrative costs and on all the sources of spending. And I would say that before we start talking about rationing and painful prescription, which is the title of a book of the 1990s on this subject, or 1980s, I think, we need to just focus, I think, really on what I would consider to be the lowest hanging fruit in terms of savings. And it seems to me that one of them is on the administrative side. And we hear all the numbers about how much more we spend on administration, how costly administration is for insurers. But remember, there's the physician side of this as well. Because of the fragmentation of insurance and the multiple types of and nature of coverage, physicians are spending a huge amount of their practice time. There's been some documentation of this recently on just dealing with this multiplicity. So administration. The other thing is countervailing power on the hospital side, I think would help a great deal. It's really hospitals that drive, while doctors make a lot of decisions, it's really hospitals where the high-tech and expensive stuff is done. And also on the kind of devices and imaging side. And that kind of countervailing power could be as simple as having here I go again, a public plan that would be competing in a lot of these markets where the insurance and these flagship hospital systems are essentially colluding to keep prices up. Because by coming in and saying, here's a lower rate that will pay for these services, it creates some countervailing pressure. And that's really what's necessary. It's not going to be possible to make every decision about where cost control is going to come from. The third area, I do think we do need more data, but I think that's going to take, that kind of comparative effectiveness side of it is going to take time. The one area where it's really simple is actually the pharmaceutical side, comparatively. The VA, the Veterans Health Administration, which was mentioned earlier, has done an amazingly good job because it has a formulary, because it's bargaining for lower drug prices.
But it's done there, and it's very hard to do generally.
Yes.
Now,
but it's easier to do there than
yes,
in the doctor's side.
You know, talk about rationing. I was hoping that we would have enough time for all of you, but I think there's time for 2 more questions. So why don't you pose the question, and why don't you pose a question, and that'll give us a time to wrap it up, and I'll just have to apologize to everybody else, okay? Thank you very much.
My name's Daoud Zalatian, and I'm just a citizen. I'm concerned that whatever health care is passed is really not going to do anything to change the system, but it's just going to be very costly to the public. You know, and there's not a lot of, I worked in the insurance industry for some time, and one thing that they teach you the first week in training is that insurance is coverage for a group of people. The larger the group of people, the cheaper the cost. I see a problem with the cost of insurance being that the more insurance companies there are, the costlier insurance will be because the groups are smaller. The larger the groups, the smaller the cost should be. The question is, the way it's been spun is that, you know, we don't want to go the socialist route, and a lot of fear mongering has been around that whole issue. Is a public option against American values? Is that at odds with American values?
Good. You got the question. It's clear the question is, and the question over here.
Name is Cohorn. I'm an emeritus professor of surgery here at Yale. My question is that you have not addressed to any great extent. Do you think that any meaningful medical reform can occur unless the major profit motive is taken out of medicine among physicians, among the whole industry? It's a thriving industry, we're told by the press. And secondly, half this country is against sharing their insurance of whatever type with their fellow Americans. And I think that's a major problem that needs to be dealt with.
Okay. It's not the bewitching hour, but there's 2 questions on the table. This is close to the end. Let me start with Stephanie. You can respond to either of those questions if you'd like to.
So I think your question was, is a public option at odds with American values? And I think that's an extremely hard question to answer because I think we're a diverse population with a diversity of values. It does not seem to be at odds with our stated goal. If I go back to my concept of holding that goal of comprehensive accountability of the delivery and financing system for health and healthcare, it's certainly not at odds with that goal. Certainly there are many details of implementation that seem to be at odds with people's values, or else we probably wouldn't be having the debate and their interests and coming to earnests. And also I'm sure that there is some concern about the public system driving out some of the profit motive or profit opportunity in the system as well.
Jacob.
Well, I want to just first say that I'm sorry that we weren't able to get all the questions, and that this certainly was a civil discussion and an illuminating discussion for me. It was very informative to hear your perspective, and I appreciate it very much. I think that the question of whether a public plan it would be at odds with American values has a relatively simple answer, actually. No. We do have a diversity of values. And yet, we also have decided in core areas of American life where markets don't work well that there should be a place for the role of government. And the role of government that I'm advocating is in many respects a limited one of providing a check on private plans that in many cases are not delivering and acting on the values we believe in. which brings me to the second question about the profit motive. I think this is a really fundamental issue because if you look at other countries, even those like the Netherlands and Switzerland that have relied heavily on private plans, what private plans are is quite different. They are quasi-public in important respects. Even though there are problems in those countries, the kinds of behavior we see on the part of private insurance plans simply have not been allowed or have not occurred. And so we're not dealing with a room full of kittens here with private insurance. I think we're dealing with a room full of lions. And while I think that we need to regulate private plans to make sure that they live up to very important values we hold in common, such as the idea that if people are sick, that they need care, we should also, I think, have some auxiliary precautions, if you will, a chair, if you will, as we go into that lion pen, and that's what I think a public plan could provide. But we're having a debate, really, about what American values are. I believe strongly that Americans do want everyone to have coverage. Certainly surveys suggest that, but I understand that they're concerned and scared, and I would be too after hearing the debate of the last few weeks. What I think and hope is that if there's more of discussion like the one we've had today, that people can decide for themselves whether it's consistent, at least with their values, to ensure affordable quality care for all Americans.
I'm going to be a moderator again and just say very briefly that I think, as with my other colleagues, that it has been the kind of discussion we would hope. On the American values point, though, I would just say that there's been nothing but demagoguery about American values in this area, and that we should be alert to it. The shamelessness I mentioned at the outset is a characteristic of the political debate we've had. And there's a mistake that is common in this area, which is to take frustration with getting progress as evidence that American values are being violated. I don't believe that for one moment. I think at the core of this discussion, which has not been as well articulated even by that articulate president, is whether or not access to medical care ought to be treated like any other market good, that you get what you pay for, or whether it ought to be considered what I would call a merit good, which is to be allocated by medical need and seriousness of trouble. That clear articulation of what's at stake is a substitute for the profit motive point that you're making. And I think what's so crucial, the last point I want to make as we leave this, is that if we had forums like this, in which if someone distorted, misrepresented, lied, or was shamelessly misrepresenting the situation, that they would be rebuked. The sad thing is we don't have forums like that. The costs of being outrageous have fallen dramatically over my lifetime. And now that I'm Medicare eligible, I'm extremely conscious of the extent to which the young have no idea about what Medicare was for, why it was advanced, what social insurance is. There's a lot more to be done. Thank you very much for coming.
Thank you.